the Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients. Welcome back to the P3 podcast. As always, I'm Talysha, joined by OG P3 Jackson Tisdale. How are you going?
Yeah, great. Really good. Little fella is still asleep, so we can keep powering on with recording these podcasts. I love it.
The 3-hour nap window is amazing.
Yeah, it's good now. No longer every half an hour or so. He gets down for 3 hours at a time, which is great.
Yeah, I know things were getting pretty dire for a while for all involved. Me, not so much, but you definitely. But I do miss a little man. I'm going to have to come over for a visit soon.
100%. No, he's going well. He's running amok and running up and down stairs and kicking balls and stuff now, which is exciting and fun for me. So it's good.
Awesome. So what we're going to be discussing in today's episode is orthoses and where they can fit into our load management and musculoskeletal pathology management treatment regimes. Now, we're not going to be talking so much about the biomechanical and the script elements. We'll be talking more so about the subjective and the prescriptive elements that surround our orthoses prescription and the clinical reasoning and where that can fit into our management programs. So the first question that we're going to, or topic that we're going to explore is where orthoses may fit into our rehabilitation programming. So first up, Jackson, I'll hand it over to you. Like, where do you see orthoses fitting into musculoskeletal pathology management?
Yeah, so I really like prescribing orthoses. I feel like they're a really powerful tool for a lot of people in their management. I feel as though they fit in when you're trying to take load off a particular structure that might be injured or irritated, or if you're potentially trying to optimize mechanics for whatever reason. So yeah, but most commonly used when you're trying to take load off a structure, either chronically sort of injured structure, you're trying to deviate some pressure or some tensile stress away from the area, or to allow it to recover, or even acutely as well, or just to take some load off the whole system, really redistribute some load to allow someone to maybe continue on with their exercise rehab a bit more effectively if pain or the mechanics of their foot is a barrier to them achieving the goals of their rehab program. If there's a bit of a cycle of pain or something that we sort of just can't get out of, we're a bit stuck, then an orthotic can help to sort of break that cycle, if that makes sense.
It makes perfect sense. And I love the fact that you didn't at all include the alignment and the corrective elements that we know aren't really accurate when we're describing orthoses. Now, I will sort of preface this with, we're talking about functional foot orthoses. So with this, it is a little bit different. So I know some orthotists and prostheses, orthos and prosthetics. I can't remember the name of that profession. Anyway, orthotics.
You've disrespected them from the outset.
Yeah, I know, my bad. Sorry, guys. So this isn't going to go well. But essentially with orthotists, like, we're not talking about ankle foot orthoses or some of the other orthotic devices that may be used elsewhere in the body that are more seen as corrective devices as far as alignment and so on. We're talking about functional foot orthoses, more so in the podiatric sense. So this is where orthoses are considered load management devices, in my opinion. So like Jackson said, they help alter the magnitudes of loads and can help redistribute loads. Do they align things? No. It's like when we see the god-awful picture where we've got that overpronating or hyperpronating foot and there's a nice big red line marking out the angles, and then someone's standing in an orthotic and everything's nice and vertical. We do know that that's not an accurate depiction of A, what they do, and B, how they function. So we're talking about the load management, load distribution element of them. And So one thing I do want to hone in on is one thing that you did mention was either using them acutely or for the long term. So do you feel that orthoses can have short-term use, or for the most part, do you feel that orthoses are more a long-standing management treatment option for patients, or does it fit somewhere in between?
All the above. Definitely, probably fits somewhere in between. And it's 100% contextual as well. It really depends on the patient in front of you, their goals, their activity levels, their pain levels, their injury, what you're trying to achieve. You have to factor in all of this stuff into your considerations when it comes to, do I prescribe orthotics, and then what type of orthoses, etc. do I use? Like it's hugely contextual. Whenever we discuss the topic of orthoses or orthotics, foot orthoses, I feel as though people can be very biased in one direction. Like they either really hate orthoses, like no one should be in orthoses, they're the worst thing ever, they make your feet weak, you lose all your strength there. And then you've got people on the other end of it where everyone goes into an orthotic and they're the solution to all biomechanical musculoskeletal problems, and then you've got people somewhere in the middle, and it's probably none of the above. I feel as though it's highly contextual, and you can't be too black and white with anything, but definitely foot orthoses. And what complicates that is the research element to it. Like there's not a lot of good research when it comes to foot orthoses because it's just plain difficult to do and expensive to do. And there's the whole art side of prescribing orthoses as well, not just the science behind it. So it's very hard to standardize across practitioners, across pathologies, across orthotic laboratories that make the devices. It's just too hard to standardize and do really good comprehensive research on foot orthoses. So that's where a lot of people who have more of a research bias come unstuck, and then potentially people who have more of a biomechanical sort of alignment bias maybe don't understand the other side of it as well. So it's a controversial topic, and I don't think it needs to be. I think we just need to see orthoses as a really useful tool for the right people at the right point of time in their rehab journey.
Oh, I agree with that 100%. And it is like, I think black and white thinking as far as everyone needs orthoses or no one needs orthoses, I think that very much sells our patient short of potentially achieving good clinical outcomes if we're approaching it from either end of that spectrum, because it may be, yes, appropriate for a handful of clients, but then we may be ostracizing the rest of them, which might be the vast majority, because we're not tailoring our treatment interventions based on their clinical and therapeutic needs. We're coming at it from our lens of bias. And I very much agree with your insight as far as where the shortfalls happen in literature, because if we're looking at some research papers, so orthoses for the management of, let's say, plantar heel pain, when we sort of zoom out and have a look at how many different risk factors and various clinical presentations exist for a pathology, it makes it very hard to prescribe orthoses, because if, let's say that there's 30 odd identified risk factors, we may have 20 people selected for a study, that a handful of them may not have any biomechanical metrics that are contributing to their clinical presentation of plantar heel pain. Then you may have some others that they are. So that's going to skew the results of the efficacy of the orthoses for those that do or don't need them. So this is where it is very much, it's that evidence-informed care is instead of that sort of blindly following the evidence. So the research says that orthoses weren't that effective for treating this particular pathology. But then once you have a look at the individual responses instead of where everything sits as far as the mean goes, for some people, they may have been significantly effective in managing their plantar heel pain, but then for other people, they may not have done anything at all. So again, it's that context and then applying it individually to the patient. So I think that's a very good point to hone in on, and where as clinicians we probably need to move more into the grey area and understanding that there is that nuance, that not everyone needs them. Some people definitely do need them. And then that probably moves us into the next phase of that thought process of how often are they going to need to use them. So what are your insights in regards to that, the longevity of use of orthoses for our patients?
Yeah, I'm going to be boring again and say that it depends. So, um, uh, some people I will prescribe a custom-made orthotic for, and they may only use it for 8, 10, 12 weeks while we're managing their certain pathology. And then beyond that, I educate them from the outset. I say, okay, from that point onwards, once we've got your symptoms well under control, you may only need to have these sort of up your sleeve for if you have any future flare-ups, or you may only want to use them when you're, on your feet for particularly long periods of time, such as all day at work, or when you're doing your sporting activity, rather than wearing them all day every day and really relying on them. Some people need to be in them all day every day for the rest of their life, and that's just due to a number of compounding factors, but that's going to be the best thing for them to continue to wear them forever. And again, there's nothing wrong with that. It just depends on the person. But other people may just have them as a load management device right now, and then therefore once we've got things under control, have them on an as is basis, or just for their longer periods of time on their feet, which is what I alluded to before. So, and I'm talking about that from the outset with people, the benefits and of them, the when and where they may need to or want to wear them, and the long-term sort of use of them as well. I think it's important to keep those conversations open. I feel like there's absolutely nothing wrong with prescribing orthoses. They could potentially benefit a lot of patients that we see, but I think where we come unstuck and where a lot of the controversy, I guess you could call it, lies, is when we're deliberately pushing them onto people and telling them that they need to be wearing them all day, every day, all the time, when they simply don't. So, but then some people do, like I said. So it just depends. And it just blows my mind how passionate people get about this topic.
Yeah.
Yeah.
And I like, that was the answer that I would have given as far as like when and how long do we use it. It does depend. So there are some pathologies that the long-term use is often going to be required. Like if we have someone with stage 2 tib-post tendon dysfunction, and we do have some breakdown of the plantar ligaments, and so there are some structural and sort of significant functional changes occurring, then there's not really, they've kind of gone beyond what a TheraBand exercise for inversion strengthening can do. So there are some instances where an orthotic device will be part of their long-term management, because that's the more conservative approach as far as sending them to an orthopedic surgeon for reconstruction if they do or don't need it. So it's taking into account the person that we're dealing with, the pathology that we're dealing with, the level of severity that we're dealing with, and what the long-term outcome for that person may or may not be. But if you've got someone who we're prescribing an orthotic device as a load management tool for an acute or a subacute injury, and we're just using the orthotic to help bridge that capacity gap while we're working on other elements to return them to their normal activities. So for that person, it may not be you need to wear them for the rest of your life. It becomes a little bit more of, we're in rehab mode, so we're using the orthotic probably more than what we're going to. And then when we go into maintenance mode, we can hopefully wean you out of the device if needed. But then if things flare, then it becomes a tool that you can use. So it's, very much a context is king in this scenario. And it's very much something that we do see it peddled so much on social media, as far as there's so much criticism and infighting that occurs in allied health. And this practitioner is garbage because they prescribe people orthoses. And this practitioner is garbage because they tell everyone that they shouldn't be wearing orthoses. Again, both sides of the equation are probably wrong if they're going at it from that black and white approach. It is the grey area, and having an understanding of, one, the patient that we're working with, and two, what we're trying to achieve and looking to achieve from the prescription of our orthotic device. So that's where I kind of sit in regards to this.
Yeah, and it that can flow into the other debate or the argument that comes up all the time is prefabricated versus custom made orthoses. Again, it depends on what you're trying to achieve and what works best for the individual. So, a lot of people say that, oh, couldn't you just have used a prefab instead of a custom device there? Well, yeah, maybe, but a lot of the time you can't be certain of what you're actually trying to achieve with a prefab. Like with a custom made device, you can control more variables and you can get it more sort of correct, in inverted commas, to what you're trying to achieve with your prescription. And it comes down to the individual as well. So for that particular person with plantar heel pain, a prefab device, just you can just know by looking at their foot, looking at their presentation, looking at the prefab device, that ain't going to work. you need to do a custom made device for their particular presentation. But the research won't tell you that, because the research is based on a group of prefab users versus a group of custom users, and they find there's no difference between the groups. But what the research fails to do is look at the individuals within those groups and how each individual responds. And we've already touched on this, but how each individual responds to the particular orthotic. So if and that's where a lot of people get, I think they're barking up the wrong tree when they get heated and they argue that, couldn't you have just used a prefab? Was a custom orthotic necessary there? When they didn't have the individual in front of them and looking at their presentation. And then it comes down to the practitioner's skill as well. So you have to be confident that you're able to achieve what you need to achieve with a prefab device compared to a custom device, and what are you most skilled in. And there's so many variables that come into it.
Yeah, I very much agree. Like, I just thinking of one example is, I had a patient quite a few years ago when I had the foster clinic, and he had polio and quite a significant, it was a very, very difficult foot to work with, and he needed an orthotic device because he ended up continuing to ulcerate under the base of his fifth metatarsal just because of the foot deformity that he had. And I opted, so he needed a completely customized device, but I went with completely customizing a orthotic. So it was a huge amount of arts and crafts that I did. So it ended up being a customized device, but it wasn't our traditional either plaster cast or scan device, because of the level of tinkering that it required. And so I selected completely modifying the orthotic because it was a heat molded material that I could get the mold and I could essentially arts and crafts it there on the spot, because it did take a lot of tinkering. So that was very much factoring into the equation the patient's needs and the patient sitting in front of me for what I was selecting to do. And so that kind of sat in the middle of a traditional custom device, because it wasn't based off a 3D model scan, but it was molded to his foot, and then probably about 3 hours of arts and crafts tinkering to get it right. So yeah, it's paying attention to the person sitting in front of us, what we're looking to achieve, what we need to achieve, and how we go about doing that. And I do agree with you that some people can be a little bit too black and white as far as, yeah, we need to go all custom, or everyone should be in a prefab. And then also one thing that we need to factor into the equation is the patient. We can give them the option for prefab versus custom, And sometimes, yes, a prefabricated device may more than achieve what they want it to, what we need it to. However, the patient may be erring towards a custom device because of health fund rebates, or the fact that we can create probably a lower profile device than a than a non-customized device, a prefab, sorry. So it's factoring in, again, the needs of the patient. So it's having those conversations with patients. So that's all of the sort of subjective elements surrounding it. So how often do you find that when you're discussing the potential need of an orthoses with your patients, are you finding that if it is a situation where you could probably get an equitable outcome with prefabricated versus custom, how do you sort of frame that conversation with your patients?
To be honest, it probably doesn't come up that often. I probably most of the time keep things as simple as possible. And if I feel as though a custom device is definitely going to be the better option for that person, just based on my experience with that particular pathology, their foot, the context of the situation we're in, and what needs to be done. If I feel like a custom device is going to be the best choice, then I'll recommend a custom device. Then if they ask about a prefabricated device, I'll go into the details of that. But a lot of the times I feel as though you can give people too many options as well. Even the option of a custom versus a prefab, considering if we're talking about rehabilitation, if we're talking about all other elements of their care as well, treatment, I mean, orthoses is one part of that. Then if you throw in, okay, well, do you want a custom or a prefab? Like, that can just be too much information, too many choices. So you're just overcomplicating things, and a confused mind says no. So then they're not going to choose either, or they're going to go with the prefab option, which may not have been the best option for them. And then they're going to get pissed off at you later down the track when you then say, okay, we probably need a custom device. Well, hang on, I've already paid for this prefab device that you recommended. So I find you have to, it's a bit of a skill set to really know what's going to probably work best in your hands as a practitioner helping them, and then just recommending that. If I am, however, if I do feel like, okay, I could probably achieve this result with a prefab may be more appropriate here, then I'll give them the options, right? And I'll say, look, I could probably, we've got two types of orthoses. We've got a prefabricated device or a custom made device. And I'll say something along the lines of, a prefabricated device is basically it's off the shelf. Anyone could wear it. Okay, it's not molded to your foot, but it can achieve a good result in what we're trying to achieve. It can still offload those tissues there temporarily for you, and would probably do a good job, and it's a lot cheaper. Or we've got the custom made device, which is more of a longer term solution. If you wanted to have something up your sleeve longer term, that you can just whip out, even years down the track, that may achieve the same result, and it's still going to hold up, the durability is better, then we've got the custom device. It's a little bit more expensive, but it's more durable, it's custom molded to your foot. So essentially, nobody else could wear it unless they had a very similar foot sort of shape. So yeah, I just give them the two options then and explain the pros and cons of both. And I say, okay, what one sound, I'll probably bring out I'll show them the difference between the two. I'll show them the prefab, I'll show them the custom device, what they sort of look like. And then I'll then ask them which one sounds best to you. And then they make the choice. So yeah, I find, and that's all considered as well with, what you're trying to achieve. Like I said before, you can't, just because if you want to go down the orthotic pathway, you can't feel like you need to offer prefabs as a solution purely from the financial side of things as well. That's probably something we should talk about, that you can't just assume someone's financial position. If you know that a custom device is, and that just comes down to practitioner skill set and experience, if you know that they need the custom device to best achieve their goals, then you need to just recommend that, not basis off how expensive it is. That's a whole nother topic of debate.
Yeah, and it is something that, like, I find, because if I could work for free, I could. Like, if I could work for free, I would. Sorry, because I enjoy what I do, and that's something a lot of clinicians find. But one thing I've very much had to work very hard on is stopping myself assuming the financial position of patients and what they can and can't afford. So sometimes, yeah, you can make your best recommendations, and then if they come back with, oh, I can't afford that, then there's conversations that you can have around the financial aspects. But in saying that, looking at it from the flip side, so yes, as clinicians, we shouldn't be assuming the financial position of our patients as far as what they can and can't afford. We should be recommending treatments based on, in our opinion, what might be the best for our patients. And then if there's a bit of a financial barrier, that opens up a discussion for helping them potentially navigate that if possible. Now, on the flip side of this, I definitely feel that clinicians shouldn't be making their treatment decisions and recommendations based on their financial interests. So I remember being part of a podiatry forum, what was a Facebook group that I'm no longer a part of. This was maybe 2 years ago. And there was a conversation in there regarding orthoses prescription. And then there was one comment that just made me absolutely freaking wild as far as just the internal rage, as the comment was essentially, I prescribe, or you should be prescribing customs for all of your patients because that gives us the best profit margin. And I think that is complete horseshit. We should not be prescribing treatments based on our financial interest and financial margins. It should be recommending treatments that are in line with patient needs, irrespective of how much money it's going to make us. That's my opinion. And that's one thing that pisses me right off when it comes to a lot of private practice behaviors. But anyway, that's a rant for another time. So it's just the financial considerations.
Well, it all comes down to the intent behind what you're recommending. So if your intent is to make as much money off this person as possible, then obviously that's unethical and you shouldn't be doing that. But as a positive sort of consequence of recommending a custom orthotic to someone because that's what they need and that's going to benefit them, if we then make profit off that as practitioners, then that's just an added bonus to us. That's not, if it comes out of the intention of trying to help the person as much as possible, then we benefit from that because they are an expensive product. And there's nothing wrong with that. There's nothing wrong with benefiting from providing as much value as you possibly can and actually helping someone. We should be rewarded for that. It all comes down to the intention, is what I feel. So that's where you run yourself into trouble. So but yeah, it's no secret that the orthoses are an expensive product and we can make a lot of money off them. And it's something that is perhaps an advantage that we have over other allied health professions who don't use orthoses. I was speaking about this recently with Tyson on his podcast about the nail surgeries and orthoses from a podiatry point of view. That we're pretty lucky in that sense. But you should always be recommending with the patient in mind, sitting in front of you. And then if you happen to reap the rewards of that as well, then just that's great. Like there's nothing negative about that at all. So comes down to the intention.
Yeah, intention, I 100% agree. And I don't feel that there's anything wrong with us providing treatments like undertaking nail surgery or prescribing custom orthotic devices, because yes, there's a large profit margin, but then there's also been quite a significant outlay as far as the cost of us to take our studies, the cost of getting the devices made. So it's not just paying for the device itself, it's compensating the practitioner for the knowledge and how much it's cost time-wise and financially to acquire that knowledge in order to be able to provide that therapeutic treatment option. So I don't think there's anything wrong with being compensated for that. And exactly like you said, I think it's the intent behind it. Now, what I want to sort of stem off that with, because I think it's a nice little segue, is so the intent behind it. So we have our intention as far as why we're recommending a treatment, in this case, custom orthoses or prefabricated orthoses in general. So one of the things that can really, really set us up for some serious headaches if we're approaching it probably incorrectly is the treatment narrative that we're delivering and recommending the device with. So this sort of ties in with the expectations. So what I mean by this is when we're prescribing an orthotic device, are we pegging that as the panacea for their musculoskeletal complaint, or are we factoring in all of the other elements that may be playing a role in the development of their pathology? So how do you see this in clinical practice, and how do you approach that as far as your treatment narratives with your orthoses prescription?
Yeah, again, I like to try to simplify it as much as possible. So I usually I use a lot of sort of analogies and scales, percentages, etc. So and I say something along the line. It comes down to communicating the pathology that they've got and what we're trying to achieve. So using things like the load versus capacity equation, etc. So your plantar fascia is under stress here because there's too much load going through it for what its current capacity can cope with. So what we then need to do about this is we need to reduce the load going through the tissue, and then we can improve the capacity of the tissue, or we could do both. So the way in which we can reduce the load on the tissue is orthoses. Then we can improve the capacity of the tissue with a strength and rehab program. So explaining that there's multiple components and variables like that to there, and it may only be the two, but there's other factors as well, but just explaining the different variables in the pathology and the rehab of it, then you can sort of fit what part orthoses play in that into their particular compartment of load reduction. So then they're aware that there's this whole other element to it, building capacity, building strength, controlling lifestyle factors, etc. That all need to be addressed as well. So then using percentages, I might say, okay, look, we can probably expect the orthoses to have, say, a 40 to 50% contribution to the reduction in our pain here, or the improvement of our condition, and then the rest of it's going to come from modifying all of those other factors we've already spoke about, so that they're not expecting the orthoses to 100% fix their problem. Hope that all made sense.
Oh, it makes perfect sense. And it sounds like you've worked with me before, because the percentages.
I've learned from a few different experts in this area.
And that's one thing that I feel is very important at framing and setting those expectations, because it's the unmet expectations, whether or not it's us creating a false expectation of how effective the device may be, or the patient coming in with a preconceived idea or expectation as far as what the treatment would achieve. Doesn't matter where the expectation starts from, we need to manage those expectations, because if we're failing to manage the expectation and we fall short of that, then that's when we do have a very unhappy client. So like Jackson was saying, so I'll often, we'll talk about the percentages. So if we've got someone that it's a running related injury, explaining the context of and the therapeutic goal that we're hoping to achieve from the various interventions. So you've got plantar fasciopathy, and we've done our clinical history taking of the patient. So a lot of it may be related to training errors, and they've sort of scooted into a reactive plantar fasciopathy presentation. The role of the orthoses is they're going to help decrease some of the load that's experienced on the plantar fascia to essentially calm it down and help keep you as active as possible. What's going to help you for the long term is the more progressive loading and the education approaches that we're going to undertake, as far as you being able to create some sustainable training habits and sustainable increases in training loads. So it's not the orthotic device that's going to magically fix everything. It's all of the behaviors that we're going to try and implement and change surrounding that. The orthoses are just trying to decrease some of the load so we can keep you as active as possible whilst taking a little bit of load off the area. So it's just really, really being clear on what the actual role of the device is, and very much moving away from that god awful, the orthoses are going to correct your foot posture, because that doesn't work. That doesn't happen. So I think the expectations and the framing surrounding orthotic prescription does become quite important. And in saying that, are there any sort of little tips or tricks, or even just lessons that we've learned from orthoses prescription that makes the process either a little bit more difficult than it needs to be, or we can have some insights to how we can maybe make the process a little bit easier when it comes to some of those subjective and sort of behavioral things surrounding our orthotic prescription outside of the device itself?
I think something that I've developed is ensuring that the orthotic scanning or prescription sort of appointment is just dedicated to that. So they come in and you spend the whole time going through all this stuff, talking about orthoses, talking about the aim of the orthoses, talking about the prescription, how long it's going to take for them to be made, having a look at all their shoes. So ensuring that they bring all of their shoes into that appointment, like literally all of them. So if they've only got their runners there with you and you plan to fit them into some other shoes, say, okay, let's get your other shoes in so that we can have a look at them before we order them, and just wait till that next appointment. Make sure you've got everything really clear and set, and dedicate a whole appointment to orthotic prescription. And that way your education around it, perhaps, and the instructions around it can be a lot clearer, and there's not sort of other conflicting sort of information, or you're trying to rush your orthotic prescription or scanning towards the end of a treatment session or a rehab session. Try to compartmentalize it. That would be my number one tip.
Mm-hmm. That's a good tip. And one thing I did in Foster, I don't know if you did it as well, but I would still compartmentalize it, but it still would be merged into one appointment. So if I had a patient coming in from out of town and we had, say, a 30-minute rehab appointment scheduled, but then we knew that there was a chance that we were going to be doing some scanning for orthotic devices, I'd turn it into a 45-minute appointment. So instead of trying to cram, so essentially it became 2 appointments, but one was dedicated, so that 30 minutes to the rehab and the musculoskeletal side. And I would literally finish that part of the consultation. So if we were doing program formulation, it would be completely finishing that like I had a new patient coming in, not that same patient. So doing the rehab, finalizing that management plan, and then that sorted, do you have any questions? Finalizing that, and then that gets put away. And then starting, okay, now we've got this appointment for the orthoses. So it was my way of, in fact, because we had some patients that would come sort of 2 or 3 hours out of town down to the clinic. So that was one kind of workaround that I can think off the top of my head that we were doing for that. But so it was still compartmentalizing, but also being mindful of the patient's time. But so creating 2 sort of separate appointments and then tackling the orthoses component almost like it was an entirely new patient that we were doing that with. So that was sort of one method that I was using to meet in the middle as far as that approach goes.
Yeah, just try not to rush anything. And it's almost like when you go and see a specialist and you're ushered into a different room to see the next person to do that lot of scanning or tests, and then you go to see someone else for the next sort of scanning and tests. So I think that's probably important, is just to be very considered and careful, and don't rush through the orthotic prescription process.
Yes. Are there any other elements that you often bring into the equation that you find are quite helpful when it comes to the orthoses and where it fits into your management plans?
I think having a orthotic review appointment, right? So an appointment dedicated to an orthotic review. It may not need to be as long as the fitting appointment. So therefore you may want to chuck some other stuff in there as well, such as the rehab, but ensuring that the patient knows that they need to have an orthotic review appointment, and the purpose of that appointment. Really explain the purpose of that appointment and why it's important. We need to check to make sure that the device hasn't lost any of its integrity. The materials are holding up solid, which we expect they will, but if there's going to be any issues, then we need to be sure of that. The making sure that it still contours of the foot, that still fits their foot well, and that it's still holding up and doing the job we would expect it to. The benefit of that, so that they can be confident and we can be confident that they're getting the most out of their orthotics, and that they're well positioned to not have a flare up in pain again going forward, and just explain what you're going to do at that review appointment. So I'll get your orthoses, I'll check them, we'll do the measurements again, make sure that everything's holding up well, and we can discuss the long-term plan, whether that's a 4-week review, whether it's a 2-week review, whether it's a 6-month or a 12-month review. It doesn't matter. I just think making it very clear the benefits and the purpose of that review appointment, because if they go away and you don't see them again after you've given them a pair of orthoses, then kind of defeats the purpose, or kind of, it's just, you're just left in unknown.
Yeah, that ambiguity, sorry, I bastardized that word. That can create a little bit of a gap and uncertainty with patients. So I do feel that having the review is quite important. And as you know, when we see patients in the clinic, they aren't like, we do it as well when we're patients and we go see a doctor or a specialist. So there's only so much information that someone retains from a consultation. So oftentimes I find the orthotic review appointment is quite important to, again, sort of review the use of the orthoses, the care of the orthoses, the role of the orthoses in their treatment, especially if you're utilizing orthotic devices and rehabilitation or exercise therapies concurrently. And it's because it is quite easy for people, especially when they start to feel better, to back off their rehabilitation. So often I find that the orthotic review appointment is quite important for reinforcing this is the role of the orthoses, this is the role of the other therapeutic interventions that we're applying or implementing, because again, once we start to feel better, we do back off the exercises. And if we're falling short of our functional restoration, then we go back into our normal activities. That's where we can begin to perpetuate that boom bust cycle. So even if the orthotic review appointment isn't something where we physically need to do a hell of a lot, it's a very, very good opportunity for us to hone in our education, our framing of the roles of our different therapies, and help keep our patients more on track and review some of those elements that we've hopefully discussed in previous appointments.
Yep. And another tip I just thought of was, I don't use the words we can adjust them or we can fix them anymore. So even though we know that we can make orthotic modifications, we can adjust them, etc. Some people may need that more than others, but particularly if you're using a prefab. But if you pre-frame that expectation that they can be adjusted, they can be fixed up if they're not quite right, which I used to say a lot, come back for this review appointment. If you're having any problems with them, we can adjust them. Then you're already on the back foot. Like as soon as they're if the orthoses or any part of their rehab isn't fitting their expectations, or they're not getting positive results, then it's automatically the fault of the orthoses then, which it may not be. So, and then you're stuck. You have to modify them. So I don't say that anymore. I just say, we need the review to make sure everything's going as expected, and to check up on how things are going and ensure we're heading in the right direction, and make sure the orthoses are still suitable for you. Yeah. So does that make sense? I just don't say we can adjust them.
Yeah, no, it makes
until they need adjusting. Yeah.
yeah, it makes perfect sense. I just was having a ponder as far as what I actually say, and I think I say because for the most part, I I'd say it would be a rarity that I'm prescribing orthotic devices and there's not other elements that are, and a lot of this is reflective of the patient cohort that I see. So a lot of the time, because I'm dealing more so in the realm of musculoskeletal rehab, the vast majority it's either education and load management, exercise programming, and so on. So it's very rare if I have patients that it's purely just the orthoses. So just thinking about what I say, it's actually quite similar. So I'll say they're coming in for the orthotic review, but it's often we're just going to assess and see how everything is going. And if there's anything that we need to address, we can address that. So I'll usually say address because that leaves it open for, is it footwear, is it orthoses, is it adjusting exercises, anything. So it's just assessing and addressing what needs to be done for us to move forward. But I think that's a good point as far as that framing, because again, it does sort of preload some of those expectations that, oh, maybe the orthotic is going to need adjusting. Does that mean it's not right at the time of fitting? So that's a good point.
Yeah, your language is really, really powerful, really important to consider what you're saying. And then, yeah, if you say they can be adjusted, then as soon as something's not going right or they're having a flare up in pain, they're going to assume that the orthotics need adjusting, and therefore you're going to need to adjust them. Or so yeah, and then that might not be considering the other factors that are leading to that flare up in pain. So the orthotics might be completely fine. So yeah, important to consider. I think just communication. Just to summarize the whole sort of topic of orthoses, it all comes down to communication, setting realistic expectations, and just explaining things well, and planning ahead, making sure everything's done properly and considered, and not rushing through the prescription process.
Yes, definitely. Are you prescribing orthoses in the first 5 minutes after an initial consultation for someone that's got plantar heel pain or Achilles tendinopathy? You've never seen them before and you haven't taken an activity history. Yes, be a bit more considered and timely with your interventions.
Yeah, 100%, 100%. I do get people come in that just want orthotics, and it is relevant to them, and that's what they want. Therefore, that's what you should give them. Otherwise, they're going to get pissed off and go somewhere else. So, but like if that's relevant to their history and what they want to achieve, and they're requesting it, then might have just opened up a whole nother can of worms. But
I'll give one clinical anecdote before we sign off. I remember in Foster, there was one patient that I had who they came in and they wanted orthoses because they'd Googled it, but they didn't want to do a biomechanical assessment. They were very limited in the clinical history that they gave, and even just from the behavior of the patient, observing what I could observe, and their refusal to engage or have a biomechanical assessment performed in order for a prescription, because they wanted prescribe custom orthoses. They were refusing all of that and giving limited information. So I refused to prescribe orthoses. We're not going to do it because you are not letting me, or going to let me have a look at XYZ, because we need this information in order to do this. And they were livid. They slammed, well, actually, when they opened the door to leave the clinic, they busted part of the shelf, things fell off. They weren't happy. But that was a situation where I was happy to refuse following the orthotic pathway, because based on their history that I gathered, even though it was a minimal amount that I got, they were very much, I feel, more a lifestyle related, psychosocial related. Orthoses may have helped to an extent, but they came in with it being the absolute panacea for some things that it was quite clear there was a lot of other things happening that was likely contributing to the heel pain. And also the refusal to have one of the essential components required for a custom orthotic device to be manufactured, the refusal for that, I was happy to refuse that, because the headache in relation to the financial gain, I don't feel was worth it. So that was probably one example where it's a bit different to that, but that was an outlier, very much so. So that was like 1 out of 1,500 patients.
Yeah, no, you got to do your assessment no matter what. That's that's funny. Was it was that at Foster?
Yeah.
Clinic? Yeah.
Yeah, they didn't come back.
Got some characters there. It's yeah, no, well, I was probably more thinking with people who have like already got orthoses and they want a new pair, or they want an upgrade or something like that. And
that's a difference.
They come in asking and saying, that's what they're looking for. So therefore, great, let's do the assessment. Let's do the scan today. I've got no problem with that. But yeah,
because the same, you do take that clinical history and see where it's going to fit into the equation. So that is a different experience. We did have some characters in Foster. Oh my God.
Good stuff.
All right. So hopefully that gives a little bit of insight into some of the subjective and expectation elements that we can adopt, employ, some insights into all of the element, or not all of them, but quite a number of elements that surround the prescription of orthotic devices and where it may fit into our rehabilitation management. Now, we do have a free downloadable resource that is a subjective orthoses review form that you can get from progressivepodiatryproject.com/free CPD. The downloadable resources are available there. And in light of us talking about having those good relationships with our specialty running companies, we do have our project that we've been working behind the scenes on for roughly a year in partnership with the running company. It is called Athletic Footwear for Health Professionals. It's a monthly subscription that will be launching very, very soon that was aiming to bridge the gap between clinical knowledge and clinical prescription when it comes to footwear recommendations, where we're going to be having monthly updates. There'll be biannual virtual in-services, so a huge amount of information to help your clients get from pathology to performance when it comes to running and running-related injuries. So to find out more about that, progressivepodiatryproject.com/AFHP. So that wraps up today's episode. As always, we appreciate it when you like and subscribe. Share this content with your progressively minded colleagues, and we'll catch you next time. Thanks, guys.